Hi everyone, I'm Mahdiya Rahman Sukanya presenting our paper on human AI interaction in low-tech, low-research healthcare systems at ACM IH 2026. This work asks a very simple question. Why do so many AI healthcare systems fail when introduced into low-resource settings even when the model themselves perform very well? We often assume that the main challenge is model accuracy, better diagnostic, better prediction, and bigger models. But after reviewing deployments across South Asia and Africa, we found something very different. In these environments, the bottleneck is rarely the model itself. The bottleneck is the interaction, and that changes how we should think about designing AI for healthcare entirely. Because the reality of healthcare in many low resource regions looks very different from the environments AI is usually designed for. In Bangladesh, for example, there are only 9.9 doctors per 10,000 people. Many clinics still operate on paper records, connectivity is inconsistent, and care is often verbal, informal, and deeply dependent on human trust. So, this is everyday healthcare for hundreds of millions of people. Yet, most healthcare AI systems today are designed around assumptions from highly digitalized hospitals, continuous internet access, and structured records. So, we asked a question: what happens actually when the AI enters into the system that don't usually look like this? One of the strongest patterns we found was that trust matters more than the automation. Doctors were often open to AI support for patient evaluation and clinical summarization, but they consistently worried about accountability. If an AI makes a mistake, who is responsible? And in many of these settings, there are no institutional safeguards to answer that question. Patients showed another important dynamic. The moment people were told advice came from the AI instead of a human, they trusted it less and were less likely to follow it. So, paradoxically, AI often worked best when it stayed in the background, supporting humans rather than replacing them. And perhaps the most important actors in the entire ecosystem were the community health workers. For example, ASHA in India, Shastho Shebikas in Bangladesh. These workers were not simply users of the system, they were the healthcare infrastructure connecting formal medicine to local communities. Which means if an AI system disrupts their workflow, if it requires too much typing, stable network, or unfamiliar interface, it simply won't be adopted. The challenges we identified are interconnected, but I want to name three that surprised us the most. First, language is far more than a translation problem. In Bangladesh, keyboard based text input is itself a barrier. These systems needs voice first delicate awareness design, not just a Bengali toggle. Second, black box output destroys trust, even when they are correct. If a community health worker or a patient can't understand why the AI said what it said, they won't actually act on it. Third, cultural and ethical norms are invisible until they are violated. Taboos around health topics, gender preference, and healthcare interactions, these aren't soft concern. They determine whether a tool gets opened at all. What becomes especially interesting was seeing how successfully deployed systems accepted to these realities. In Bangladesh, Ahmad Doctor combined cloud AI with a locally developed knowledge graph built from 1.4 million patient interactions. This system used Bengali voice interaction and local clinical validation. Its success did not come from a fundamentally superior model. It came from designing around the user's environment. In India, mental health chatbots became more effective when community health workers mediated the interaction. And in Nigeria, GPT-4 system achieved stronger acceptance when output were framed as guidance from the doctor rather than AI directly. Same model, different interaction design and completely different outcomes. And this led us to the central finding of the paper. A randomized control trial in Pakistan showed that trained physicians using an LLM improved diagnostic accuracy from 42.6% to 71.4%. But untrained doctor using the exact same system benefited far less. The model didn't change. What changed was the human AI interaction, and that is the variable that matters most in these settings. So, what does this means for how we design? We distillate five principles, but two are most critical for this community. Localized, don't just translate. This means grounding models in local clinical data and disease pattern, not adding a language option to the system trained on Western EHR data. Our Doctor local knowledge graph is what made it clinically relevant and designed for mediated episodic use, not just for continuous automation. In low research setting, AI doesn't sit in front of the patient. It sits behind the community health workers who hand off to a nurse and who reports to a doctor. And the handoff is the design problem, so the framework has to account for the chain with clear human responsibility at every step. For this community specifically, I want to leave three things. First, interaction patterns from digitalized hospitals do not transfer. We need to design knowledge built for low connectivity, low literacy, and mediated care, and that knowledge is still scarce. A second, interaction failure is a patient safety issue here, not a usability inconvenience. When a language breaks down, when a community health worker ignores an output they don't understand, the downstream consequences is a missed diagnosis or a delayed referral. And third, the policy implication is clear. AI literacy training must be built into deployment, not offered optionally afterward. The Pakistan RCT approves the gap is not the model, is the human in the loop. So, if we want AI to genuinely improve global healthcare equity, we cannot only optimize the model, we must optimize the interaction, the language, the workflow, and the trust. Because ultimately, the model is not what determines whether AI succeeds in the environments. The interaction does. Thank you.